8:31 and go to a roll call. Kristen, can you call the roll, please?
Supervisor Canepa,
Here.
Supervisor Ding, not present. CAO Wilverding,
I'm here.
Ms. Hopkins. Here. Ms. Vanstein. Here. County Council Kiernan.
Here.
Ms. Macedo. Here. Mr. Wolkamp.
Here.
Mr. Diederich. Here. Mr. Castro. Here. Mr. Nunez. And Mr. Zuniga is unable to join us today.
Thank you, Kristen. I'd like to move on to our action item. We have one action item, and that is to approve the minutes from the October 18th, 2023 meeting. Do I have a motion to approve the minutes?
Move to approve.
Do I have a second? All in favor, say aye.
Aye.
Noes? Alrighty. Moving on to our first information and discussion item is to present the 2023 financial results through October for our county clinics. And since Mr. Zuniga is not here, I'm going to turn it over to our Director of Healthcare Services, Greg Diederich. Greg?
Thank you, CEO Wilverding. We presented these last night at our SJ Health Board meeting, so they're pretty fresh in my mind. Unfortunately, Chris has some sort of issue where he can hardly speak, so I'm filling in this morning. So as Jay mentioned, these are our fiscal performances through October. And if I could go to the next slide, please. So you can see this is our trend line of billable visits. The top line is current year, and it superimposes the prior 2 years. We've had a drop in visits. It also displays our payer mix, primarily managed care, Medi-Cal, but also Medicare and Medi-Cal. So of our payer mix, 96% approximately are all state or federal payers. Next slide, please. This goes over our performance month to date as well as year to date. It's a little small for me to see, but you can see that the drop in visits is driving a negative top line revenue number. We're also having negative experience compared to budget for our grants. And grants are items where we may have received the grant funding, but it's on our balance sheet. We can't recognize it as revenue until certain milestones or documentations are presented compliantly, making some progress on that. But you can see the year to date, our revenues are under budget. Correspondingly, we're also way above budget on the expense line for professional services. We are hiring quite a few locums, and actually some good news on the provider front. We onboarded this Monday a permanent provider. Another provider will start in February, but we've also onboarded a number of locum nurse practitioners and PAs, and that's really to provide access and to drive that top line visit volume number. I know one of the things that Chris will point out is our benefits are way under budget, and I know we get a composite rate for retirement and then some other overheads, but we will consistently be trending well under budget for benefits throughout the year, just because our actuals will be less than the composite rate provided during the budget cycle process. But fiscal year to date, a slight negative budget, but we're also coming in a better than budget on our overall expenses. Next slide, please. This is an item I know I expressed a little bit of displeasure with, because I view the county clinics as the composite, the partnership between the county and the nonprofit board. This breaks it out, and my umbrage, if you will, is that top line where all the revenue is sitting in the FQ cost center, but all the labor, which is county employed civil servant labor, is in column 3. So it looks like, you know, the health center's gangbusters with money, and the county is anchoring it down. At the end of the day, it's that very last column, and that's reflected from the prior ones, where in total for the calendar year, we have a slight $19,000 deficit. Next slide, please. This is our variances, and as I mentioned, we look at variances that are plus or minus 10%. It's in the packet, some of these variances. Obviously, highlighting the grants, I think the grants budgets, when it was presented, was kind of straight line, so recognizing 1/12 of the projected grant revenue throughout the year. A lot of the grants are kind of backloaded, as well as some of the grants are with milestones. So I do anticipate a pickup in their recognition of grant revenue as we move forward. And I alluded to some of these other variances on the prior slide. So next slide, please. We have a very strong balance sheet. You can see our net assets over $40 million. We obviously have some accounts payable and some other liabilities, but a very strong balance sheet here as presented. Even though we have a $20,000 loss year to date, again, I'll repeat, a very strong balance sheet position. Next slide, please. This is our cash collections. You can see we broke the trend line last month and we're coming back up, and this pretty much follows revenue, billable visits, and those have dipped, but coming back up slightly. But again, as we onboard those locum tenens and permanent providers, that should drive the visit volume. And also, if you go to the next slide, I think it talks about our AR cycle as well. But here's the billable visits. Again, we broke through the trend line and we're less than the last year on billable visits, and this superimposes on the right side the cash collections. Next slide, please. This is items we report to HRSA. The cumulative cost per patient, you can see we're at $788, where in the last couple of years we've been in the 1300s. This will start to trend toward that mean as we move through the balance of the fiscal year. More and more costs, fewer and fewer net new patients going into that denominator. But the medical cost per visit, $343, I would state that is above every single one of our PPS rates. So currently our cost per visit exceeds our reimbursement on every visit. Next slide, please. These are the 5 elements that we commonly track based upon national benchmarks for our healthcare space. Next slide. So you can see here operating margin, again year to date, a slight deficit, again with the bottom line, but reflecting the days cash on hand, very strong position there. The net receivables, or days, 31 days we turn over the receivables, and I was part of coming to the SJ Health meetings 5 years ago, and I would say that was 100 days back then. So over the last 3-4 years, this got generally significantly better with revenue cycle management. And again, until we can increase the visit volume and take advantage of some of our fixed cost, namely a lot of full-time staffing, our personnel expenses as compared to revenue is exceeding the benchmark standard. Next slide, please. And with that, open to any questions or comments that there might be.
Just a couple things. You know, on the overall cost, we talked about this last time, and you look at from the time you looked at your overall cost at about 16 million or 4 million for the 16 million for the first 4 months, meaning an overall cost of about 48 million, which is over 100% greater than it was when we were in the hospital in 3 years. So that's issue number 1. Issue number 2 is for the QIP, which is so important to the county. Let's forget how it's allocated, but so important for the county. What is the delta that we didn't collect on that 59 million potential? Do you know?
I don't know, but Rick, to your comments, indeed, that top line revenue, 24% of it is not earned revenue from patient visit, it is QIP.
Right.
So the health center is not profitable without the QIP allocation. The first several years of the Quality Incentive Pool program was pay to play. Basically, you signed the attestation, you got the money. Last year was the first year we had to start actually attesting and finding the data, and that was the first year where SJ Health actually ramped up. So a lot of those positions are in business intelligence and actually acquiring the data. Had a couple positive meetings with San Joaquin General Hospital and the partnership there. The the percentage for QIP we presented is the floor. I think we are coming up quite a bit. We're putting items in place now with lead testing, doing that at point of care, the mammography, the pediatric visits. So we are working to close the gap for QIP over the balance of this year and setting systems in place that end the next program year, calendar 2024. Hopefully a running start, and we'll be hopefully above 90% of that. But to your point, the monies from the last program year that we thought would be about $7 million in that pool, I think are closer to 9, but Abe would be probably closer to that number than I. But I think we're not going to get to 100%, but I think ultimately at the end of the year, when we attest next June and we do some adjudication, we're doing a lot of work with CMC and other outside OB providers that we can actually get those medical records in the fashion we need to actually have claim and auditable. But I'm hoping we will meet or exceed last year's attestation, which I believe the final audit came in at 87% of the metrics.
And then the last question is, and this is just a suggestion, so we're out in Manteca, we have a 17 unit clinic there, we're paying $20,000 a month for the lease, and we're staffing it with locums for the most part, correct?
Correct. I have an issue in Manteca in that we're a look-alike clinic rather than a 330 grantee, and beyond a lot of the other distinctions, I can't employ a J1 visa candidate. Some of our hired doctors are visa candidates. I can't employ them in Manteca because it's not a health professional shortage area. But some of these nurse practitioners, PAs, we're trying to staff up that clinic because indeed it is significantly underutilized.
Would we be better off looking at another possibility? I know CMC would be interested in leasing that building, and I ask that because if you look at what you talked about, your rate per patient, until we can get it below the PPS rate, every additional patient we get is an additional loss. So in Manteca alone, if we're using locums, they're running somewhere between $6,000 and $8,000 a day for a locum. That's correct, because we pay them those kind of monies. To try to staff a clinic with 17 beds is seeing how many patients a day.
And I'd say our cost per locum is significantly less than that. If we look at OB, there's on those rates, but for a family medicine doctor, we're looking at probably $220 plus incidentals, travel, motel, car. I don't know the specifics on that lease. I was around when we got that lease, and then we shuttered the FQ. But I don't know if the county can subcontract that lease or assign it to an outside entity. So therefore, after they shut the clinic down, it became kind of medical records for the hospital. 8 months ago, under Dr. Perdue, they started it back up again. I don't know if it could be outsourced. I don't know if it's proper for this committee, but I am aware with my dialogue with Christine Noguera on a dental contract that they would be more than willing to take over that space.
And I'm only looking at cost opportunities in the short term as we try to reallocate to get better PPS rates. So those are just my thoughts.
And we're working on some strategies. I know, Abe, we were down at the CAPH, talked to Rod Rosenstein. We're doing a couple things. The strategy that was employed to you mentioned a lot of new costs. That the strategy I understand at the time was let's add cost to the numerator such that we can get a new base rate, and that will pay off with a higher PPS rates going forward. Preemptively, we work with DHCS to make sure, because this would be a play where we ask for new rates, but since it's a hospital affiliate FQ, we have to wait for your CMS audit before our rates would be finalized by audits and investigations at DHCS. That might be 5 years. We proactively reached out to them, and even though the SJ Health County MOU, which has a lot of purchasing of services from the hospital, that will pass a gap audit because they're correctly categorized as far as expenses. Some of those would not pass value at this cost base. So we were fearful that if we went down that route 5 years from now, that the rates would not come through. So we're looking at another strategy, and it might take some legislation, and I know Rod Rosenstein and Foley Lardner is looking at that, working with Senator Eggman to actually have it codified in law where we can transition to interim clinics, 40-hour clinics, and bill at a home office rate. And actually, if you're aware, we have 7 clinics, but really those are 3 physical locations. So in French Camp in California, physical locations, those 2 sites, both 3 PPS rates. A large disparity in those PPS rates, but what we're trying to do is basically work with the DHCS as well as CMS, HRSA at the federal level to make two of those sites intermittent and bill everything at the most preferential PPS rate. That would be about a $6.7 million pickup in revenue if we can get that accomplished.
My questions.
Do we have any other questions?
No, just a comment. The QIP metric results for calendar year 2022 for the other public health systems, Greg, they should be published around the February, March timeframe so we could compare how we rank relative to other facilities.
And I think we're probably second from the bottom.
Yeah, that's where we're expected to be.
You know, the reason we bring this up, we're not here to this isn't be critical or anything. But I think it's important that this board understands that both from a cost perspective and from what we left on the table perspective, we're looking at a number around $30 million. Those are significant numbers in my books, right? Forget the allocation. It doesn't, county's the county, right? Whether it comes to the FQ, whether it comes to the hospital. I wasn't part of, and nor do I agree with any of the time it takes and effort it takes to do these allocations, because realistically, in my mind, it's the same bank. It's just a matter of, are you putting it in the left pocket or are you putting it in the right pocket? My concern is more, we've seen, expense, and this is, well before your time, but we've seen the expense go from 21 million to what's calculated now at 48 million. Now, I know it's been a heavy inflation year, but not that heavy. Right? So that expense part is, should be concerning to all of us. And we believe, in addition to that, there's an extra 20 million that we left on the table because we didn't perform in the QIP. What we are trying to recover from is some challenges that are affecting both the hospital and the clinic. And I'll give you the best example that I can. And the previous leaderships want to bring on physicians. They offered them things that were unrealistic in my mind. These are employed physicians, and productivity, we don't have it in any union contract. We don't have any control over it. We quote unquote granted our physicians to work 10-hour shifts, and that's fine. We understand balance of life. But what they have decided those 10-hour shifts are their regular 8s, and then we'll go home and do 2 hours of administration time. So in one fell swoop, we cut the overall productivity for the clinics and some of the hospital clinics by 20%, right? Because if you worked 5 8s, clinics would be open Monday through Friday, 8 to 5, and we'd be able to see more patients. If we're gonna go to 4 10s, that means the clinics, there's opportunity there, right? We can either open at 7 in the morning and have the opportunity for people to come to clinics before work, or we could extend till 7 at night, whichever way they wanted to do it. I interviewed, we had a psychiatrist that has been challenging. She came to the hospital, looked for an opportunity there. Psychiatry in hospitals are really important. And I started talking to her, and she, said, well, I don't really produce billables. I help the docs. Well, BS, right? That's BS. No billables. Psychiatric care is a billable procedure. And I said, what do you imagine your schedule to be? And she goes, well, we're all working 4 10s. And I said, so are you going to work from 7 to 5:30? Are you going to work from 8 to 6:30? Oh, no. We work our 8 hours, and then we go home and do administrative. We have a 20% no-show rate. There's plenty of time to do administrative. And we have to take our physicians from that. If our physicians want to be employed, which we do across the board, we have to have the ability to manage their productivity. We have a OB contract where our doctors get paid $25 per patient after 8 patients. After 8 patients. That's insane, right? So we have to bring our costs. We have some big issues coming up with the UAP contract. We're very proud of the medical staff we have. We produced some really good docs in a really hard place to find them. That's good news. but we have to have some control, you know, over their productivity. I'll give you another example. We had an ENT doc that we have been scrambling and scrambling and scrambling to please because he's so concerned that the other people on the contract side are gonna get more to him. He quote-unquote works 4/10s. This is my issue, not a clinic issue. He has now signed 4/10s in one day at his clinic. And now he's signed up on a separate contract for a day at the VA clinic. Well, there's 5 days in a week and he's committed to 6, right? Getting different paychecks for every one of them. So we have to, on the union side, and I'm talking both from a hospital and the clinic's perspective, we have to have some measures that allow us to demand the kind of productivity. And it's not, we don't want to overwork them. We want our clinics to see, you know, 25 to 30 patients a day per physician like all others do. Because in addition to our physicians, we also have, thank God, residents who share the workload. So those numbers are not unrealistic, and we are nowhere near those numbers in specialty clinics as well. So we have this opportunity from the clinic side to feed the hospital, to fill all those clinics, and we just need to do, and we're getting there. We are doing some better things since Greg took over, and you know, my hat's off to you. Much better collaboration between the physicians, but the mess that we have, if we don't get in front of it from a physician perspective, that cost is going to go absolutely out of control. And our physicians, if you look at it, I don't have the most recent MDMA information, although it's ordered. But when I look at it compared to what I'm used to from Southern California, I would suspect that our physicians, as they're paid right now, are in the top 75th to 80 percentile, right? In a place where the cost of living is pretty minimal. Now, I know Stockton's a challenge sometimes to recruit to, but those are really, really, really good rates that we're giving them right now. And my understanding is the first pass in the union was significantly higher than that raises, even though they just received an 8.5 this year. And realistically, we should be keeping them to around 3% cost of living, period. That's my opinion, because in some cases, you know, we're not getting productivity. We can't demand it. It's not in the union contract. Shame on us. So we can't, yeah, we've let them kind of run loose. I know Greg has done a great job trying to bring them in. We're doing the same thing, but we need some leverage from the union perspective so we can push the business like it's a business, right? As opposed to, it's great we have good docs. We're not asking you to work like, you know, blue-collar line workers. We're just asking you to see if we could get productivity even at the 50th percentile, which is average, and I'm not a big fan of average, but if we could even get it at the 50th percentile, we would be able to see significantly more patients.
And Rick, I know I think we've shared the same opinion there. I'm wanting to move to the point where telemedicine is a benefit for the patient, not the physician. All physician paid hours, I believe, should be physically in the clinic. Beyond the 4/10s, we have some 3/12s. Well, that's 3 12-hour shifts and then a 4-hour shift at home for admin time. I had a critical conversation with a physician who's on a 12-hour shift, shows up at 8, leaves at 4. Oh, I attended all my patients. I'm available by phone. I told him no, he had to be in the clinic. Very pleased he gave me a resignation. But we need that accountability by the physicians. I'm still 4/10s, if they're physically there 10 hours a day without a paid lunch and attending the physicians. I don't mind that because some of them will give me a 5th 10-hour day, and on the margin it's cheaper than a locum, but it all comes back to being physically present and attending to the patients and getting to 3+ visits per hour.
My question. When does that contract open back up for
January.
January?
January. But every time there's a union contract, it expires in January, and most likely it's going to be March, April, May, June.
So Supervisor Canepa, we're actively negotiating with UAPD right now. We've had probably about 4 meetings. We have another 4 or 5 meetings scheduled.
But Randy, I'm correct, the union contract expires in January, correct?
January 6th.
Thank you.
Insurrection. I just have a few comments. Merry Christmas, everybody. It's, my conservative side applauds you for running this like a business, but it's not a business. You know, in the end of the day, the county, you know, takes in so much money from the state, the feds, we have our county budget, and if we have a healthy community, people aren't living on the street, people are safe, we've won. Measuring our goals not by the programs we create, but the people we serve is kind of my goal for next year, looking at this. Just a couple, this is your wheelhouse, everything you're discussing is back end. And the only thing I can associate is the trouble I had, I didn't even know there were clinics until June. And, you know, I've said this over and over again. We still have, you can spend all the money you want remodeling your businesses, you know, what have you, but if you have no clients because the clients don't know you're there, I would like in the future a little more conversation about how we're going about getting clients in those facilities, because I think we still have a communication problem, and we're not discussing that, and I think we need to do that as well. But other than that, thank you.
A majority of our patients, though, do come from the health plan. So again, a county-run organization. So there is a need for, we're not making up empty slots that can't be filled. We're making up, if we're more efficient with the way that we do things, if we overbook because we have so much absenteeism, then we are actually doing exactly what you want us to do, and we're having more access for our patients, which is critical. You know, the one thing, and I keep saying this, that was so exciting about coming here is health plan, clinics, hospital, behavioral health. The prison is just a ribbon on the cake, but the opportunity to truly manage population health, and I understand, I would respectfully disagree with you about how we run them as a business or how we run them as a county, because there should be no difference. There's no reason that a county hospital has to operate differently than, maybe not as aggressive as a for-profit hospital, but certainly in the same tune that the Dignity Healths of the world and the Sutter Healths of the world and the Kaiser world, because it's kind of the same game. So I think that it is prudent for us to set the example of making sure that we run a cost-effective system and increase the access for the most underserved patients in our community. So that's, you know, we have all the components to do that, and we are gradually improving from where we were, you know, 6 months ago or 4 months ago. But I would, you know, I think that we need to push as hard as we can to run like a efficient health team, because health expenses are so inflationary and going up so much as we speak. So that's just my opinion.
And my comment, I think, was more of a shot at myself, because I like the fact that you're cost conscious. But the other thing that I'd like to see, and again, when you're pushing a pencil on a piece of paper, it's really hard to figure out what you're saving on the back end. If we've got, you know, we've heard a lot, you know, supposedly I'm only supposed to eat red meat once a week, which I'm doing. I've been really good with green teams and preemptive health care and everything we're supposed to be doing by increasing our clients in the clinics, if we ever move down that path, by increasing individuals in those clinics. What are we saving on the back end? You know, that, so it is run like a business. So at the end of the day, we don't have sicker individuals because we've taken care of them in the front. So
All of the metrics for QIP, all of the metrics for GTP? GIP, too many acronyms, right? All of them are based on, and this is the state pushing population health. All of them are based on metrics that do exactly what you say. So when you look at the QIP metrics, say for colon cancer, Their question is, how many of your members got their Cologuard every 2 years or whatever it's supposed to be? How many of your 40-plus females got their pap smear? You know, those are the kind of things that if we really get in front of, because we bear the burden, and I can give you examples of patients that we've had for, you know, one patient we had for over a year because they weren't healthy all the way through, and that, the end cost of that, I think about that, is millions of dollars. So, that's what the state is pushing. That's why they push the QIP metrics. And that's why, as I told you guys all along, that's why that money goes to the hospital. That was the design when they developed these quality programs to say, look, as sad as it is, too much of our care is delivered in the ER. So we're gonna change that. We're gonna make an active effort to change that throughout the community. And we know you hospital will be affected because even though it's not the most effective way to deliver care, it's a very high payer. We know you'll be affected, so if you do these things right, hospital, we will protect you and we will give you these QIP dollars. Now, the way, you know, that we've talked about, these should be run as, is like an every 2 week, where do we stand, where do we stand, where do we stand? Because we have, since Greg came, tried to pick up the mat and try to recover as much as that as we can. But those metrics in Contra Costa County and those metrics in, what's the other one? Alameda County, you know, they're both running at 100%. So, you know, when we talk to them, that they do it like on the for-profit side, when we see other, whether it be denials or see an opportunity like QIP, there would be somebody that would manage those statistics on a day-to-day basis to make sure that we didn't find ourselves in October trying to do what we should have done all year long. So I think there's opportunities to improve those as well. That's just additional revenue for us, but we have to, you know, understand where we stand now. Probably the more patients we see, the you know, maybe the worse that we do, which is. You know,
But I'd just add, no margin, no mission, but we're here for the mission. We're the safety net. I like the concept of working more closely with the local initiative health plan of San Joaquin, 94% market share, a county entity. 3 commissioners are at the table today, but between the county hospital, the county clinics, and the local initiative that we developed, we have a lot of opportunities. Truly, we have 46,000 lives assigned to SJ Health. Only 17,000 of them last year actually sought services. So there's a lot of opportunity there. We're gonna look at mobile clinics, getting them around the county, including North County, and driving patient engagement, patient services. But really, I think when you mentioned Contra Costa and Alameda, SJ Health moved away from the county. I think we need to be a lot more integrated, a lot more critical conversations, partnerships, and I agree we've come a long ways with mending some fences and starting to collectively solve these issues, because indeed, drawing down QIP is great, but these measures are proxies for better preventative care and better outcomes for the people we serve.
Yeah, 25% of the hospital's revenues are tied to supplemental programs. So if we don't achieve these quality metrics, you're gonna start seeing it on the financials. So it's gonna be critical that we excel.
Anything else from the committee members? Okay. I have a couple questions and a comment myself then. Is my understanding of the Contra Costa and the Alameda they are different structures, and that Contra Costa essentially has a health plan embedded in its system. And just what you had said, Greg, they're not satellite, they're more integrated. And Alameda's an authority, which I'm not really familiar with how an authority works, other than it's more contiguous but separate from the county. It has a separate governance structure as well. So I applaud the fact that we're trying to get there, but that may only be accomplished truly getting into a phase 2 in the MSA environment and pulling a few things in. So I just wanted to comment on that.
Sure, but I think with Lizeth and relationships, there's, as you know, last Wednesday, the Health Commission approved $100 million of community reinvestment. A lot of opportunity there. 3 years ago, there was a reprocurement of Medi-Cal throughout the state. At that time, Michael Schrader was the CEO. We had some conversations. We could have pivoted because Contra Costa County went from a two-plan county model to a COS, which is a county organized health system like Merced and others. Michael Schrader came from Orange County, which was Cal Optima. There's only one managed care Medi-Cal entity in that county. We could have made the choice in our county to move that direction, but the downside there is there's no patient choice. Right now, you have a choice between Health Net and Health Plan of San Joaquin and a little bit of Kaiser. But because of Health Plan of San Joaquin being embedded in the community, being present, there's a 94% market share in this county, about 72% market share in Stanislaus. But we chose not to go to the COS model. That might come up again in another 5 to 10 years at the state level. But there are some advantages as far as integration and shared risk. So.
When you look at that number at 94% though, it's almost like a single plan. It's almost like a single plan, right?
Yeah.
Because what, 6% are choosing Health Net, correct? And I don't even know what their resources are, right? So we have Kaiser now trying to get in the Medi-Cal to pick out the Medis. That's
Yeah.
what they're going for. They're not here to take care of the underserved. They're here to say, we're gonna participate. We'll take all your really, really good patients. So we're gonna fight and make sure that doesn't happen. But I think that we don't have to, if we didn't change form at all, if it stayed the way that it was, it doesn't prevent us from working like we're one. And every conversation I've had with Greg and every conversation I've had with Lizette, I think we're all in this together, 100% together. I'm gonna share a secret with you all that you might not know. Patience is not my strength, but I'm working on it, all right? Patience is not my strength, but I'm working on it.
We didn't know that.
Yeah, this opportunity is still really ripe for us to do better than what we're doing. Hospital as well, you know, from a healthcare perspective. So I think now, different from 4 months ago, we have the right leaderships in place to work together. And I don't think that I don't think structure needs to affect us one way or the other. Like I said, when we sat down with the clinic docs and talked about what can we do to get these metrics the best that we can, it was kind of an all hands on deck. There were good suggestions. We started it the next day. And if we can continue that kind of movement forward, I think that you'll see two things. I think you'll see better quality, three things: better quality, better patient satisfaction, and you won't ever have to look at the health system as a burden on the county. I really believe we could get there. There's some tough places with the nurses and things like that, but more optimistic than I was last year, but still, I think that every day that we don't move forward is a day that we're spending money we don't need to spend.
And I would agree with you. I think we got the right people in the right place, and we're moving in a good direction.
And Jay, I'd add, we sink or swim with the health plan as well, because you said on the commission, you see that DHS is moving towards sanctions. We got a little bit of sanction, but there's 34 HEDIS measures times 4 counties, and if you're not meeting these HEDIS measures that have a lot of overlap with QIP and MCAS, the health plan gets sanctioned. So part of that funding that we broadly allocated last Wednesday, we're working with them at point of care lead testing, because they're gonna get sanctioned on that if we don't include our metrics. Probably less than 15% of the children that are required to get lead testing under the Medicaid program actually do it. That's because here's a slip, go to Quest. That's not gonna happen. So we're bringing lead testing in-house at point of care, and we're gonna be engaging the health plan saying, hey, if we increase, double, triple the number of lead tests that are being done, or increase the measure, we're gonna engage with them to have them pay us incentive monies, and that helps us collectively out.
Okay, thank you. My 2 questions were, I know there was some discussion during, I believe it was the last meeting, about how often the clinics were open and the impact of the 410s and the, what do you want to call it, alternate work schedules. How open are the, and I know, I believe Chris Zuniga brought up, they're open 12 hours a day, however many days a week, and functionally, are they open and available to take on patients during the time that they're supposed to be?
I have issues with that. HRSA requires us to put basically on the front door our posted hours. And as I mentioned, at French Camp and California Street, there's 3 clinics, 3 doors. Those posted hours, I can't always say we have a medical provider physically present. We have a vendor that does telehealth, but that's one of our strategies, and we're waiting due to the, get past the on-site visit of HRSA that's coming up in late January. I mentioned the strategy and the intermittent clinic rates. An intermittent clinic will be limited to 40 hours a week, but as I mentioned, we're co-located with other clinics. So I want to get to the point where we are truly providing the access that we're putting on the front door and truly have a physician there for scheduled patients as well as walk-in patients. So some cleanup we have to do.
Okay, because if we don't do that, then it's going to be very hard to drive it on the revenue side.
My understanding though is we have in the union MOUs, we have the ability to dictate schedules. Management has the ability to dictate schedules. So I believe that's the case. So if you went to the intermittent clinics, then we would just change from 8s to 10, or from 10s to 8s.
Okay. My last question is more of a technical one, is on the employee benefits. If you were to refer back to the variance sheet, in the year-to-date variance favorable of over $800,000, and the comments were that we had budgeted at 66%, but it was only 41% in reality. But it's because of the purchase services from the hospital. I could understand if it was because we were using outside people that have lesser benefits than we would for a full county employee. I'm not exactly sure how that popped up.
So I know Chris highlights this, and when I talked to him, and I think Jennifer Van Stein could probably help me out a little bit. During the budget, there's a composite rate. There used to be kind of a BPS worksheet where I know for every full-time employee, it was very detailed. If they were moving from step 2 to step 3 during their year, if they had a different level of family versus individual medical insurance, we had a very tight cost rate. I just don't know if that's changed, but I know Chris mentions maybe we have more post-PEPRA employees than pre-PEPRA, but the composite rate, if you have, that might not be built up from that BPS style worksheet, is higher than our actual, is what Chris is alluding to.
Couldn't it be though that you have 50 contract employees that don't receive benefits that are counted in the right? So the cost per beneficiary would be much less because those 50 people that are independent contractors don't have benefits.
Which is what I would have expected, except it said in the narrative here that they're purchase service employees from the hospital.
Yeah, so 1099 individuals don't have benefits. I think that the benefits line is driven by the people in the salaries and benefits stanza of the P&L.
And just to conclude, is if that variance should disappear as we go through the year, that's going to hurt the bottom line.
It's projected not to disappear. It's actually to keep that trend.
Okay, that's actually the best answer. Thanks, Greg. Any more questions? Okay. That concludes the presentation for the clinic's financial. We'll move on to item number 5, which is the presentation of the hospital financials. And I'll turn it over to Abe.
Good morning, everyone. On the hospital, we can go to the next slide, please. On the hospital side, our financial results are not where we would like them to be through the first 4 months of the fiscal year. From a margin perspective, we're roughly $2 million short of where we expected to be in our annual operating budget. When we kind of take a step back and look at the hospital sector in general, as Rick alluded to, it's been challenges with considerable pressures on the cost side, both in terms of higher labor cost and inflation on non-wage categories such as pharmaceuticals, high-cost surgical supplies, prosthetics, implants, et cetera. On top of that, when you look at the volume trajectory at San Joaquin General, we've seen a decline in our inpatient business. Year over year, our inpatient discharges have contracted by about 5%. And those inpatient cases are not where they were during the peak COVID periods. So really, the pressures on the cost side and the lower inpatient business are the 2 key drivers for missing the target thus far through the first 4 periods. But it's not all bleak. We do feel that there's some opportunities that we can realize to help close some of the budget gap. In terms of our volume metrics, when you look at the whole house, so looking at our adjusted patient days, which is our inpatient days plus outpatient equivalent days, we're hovering a little under 1% unfavorable to budget. Our inpatient revenues are lower than what we had expected, so that correlates with the lower inpatient discharges. But we are doing very well when we look at our outpatient business, seeing strong growth in terms of our outpatient surgeries. Trauma cases have picked up here over the last couple of months, so good news there. So while our adult days are down, our maternal child department is another service line that's trending in the right direction for us. Looking at the acuity level or case mix index of our patients, we are seeing a spike in that metric. So that shows that we're starting to realize those gains from launching our clinical documentation improvement team. So that's going to translate to higher revenues now that we're coding those claims appropriately, and less revenue leakage, in terms of payer denials. So good news on that front. When we look at our average length of stay, we're essentially right on budget. With that said, I know that our case management team is working actively with our physicians to ensure that we're discharging those patients as soon as they're medically cleared by our providers. Looking at operating revenues, I think this is a great result. We're hovering about $2 million over budget, or 1.2%. So while our inpatient business has declined, our revenues are up. And so that's showing that we're starting to realize those gains from all the revenue cycle initiatives around looking at closed accounts for underpayment recoveries, collecting on small AR balances, really leaving all stones unturned in terms of minimizing any revenue leakage, which we've seen in prior years. When we look at our supplemental payments, as we talked about earlier, because of those quality metrics, those revenues are what we recognize on our income statement is lower than what we had projected at the beginning of the year. And then on the expense side, the biggest, we're trending, $4 million over budget, or about 2.5% above budget. But it's really all under the professional services line. So finding ways to kind of rationalize our traveler expense will be critical for us as we go forward. We did get some positive news from what we understand. We're onboarding a number of new registered nurses here shortly. So in theory, we should see that contract labor line
We've
come
made
down.
offers, we've made offers to over 100 nurses in the last month. I know we got at least 50 of them. I think we're actually going through the second phase. One of the things that Abe, on the cost side one of the things on the cost side that is new to us and new to the county is the missed meal and missed break scenario, which was never a county initiative, and we knew it was going to hit us hard, and it started off at about 20 a month, 20 grand. What is it up to now? About 100?
Yeah.
About 100 grand a month, and it's a really hard measure to meet. And again, I'll give you the example of what we need to do and what's actually happening. We don't really have the ability to flex. So every time, and this is the best example. I got a call on Tuesday night from labor and delivery in just a panic. They had 11 patients in labor, and they had 9 patients in postpartum. So postpartum ratios are 1 to 4, meaning it would have taken 3 nurses in postpartum. We had 3 nurses in postpartum. Labor and delivery ratios are 1 to 2. They had 8 labor and delivery nurses, and they had 11 patients. Now, sometimes they come 1 to 1, right before delivery, but plenty of staff. And the person on the phone said to me, "I'm administrative today. You're taking me off administrative to take care of patients." And I'm thinking, did we really just have that conversation? So going back to any time they don't have a break nurse, instead of just, finding ways to work together to get their breaks, everybody gets an hour. They don't have a lunch nurse, everybody gets an hour. It's not, we have to have some levers, guys. We have to have some levers to say, we're gonna go manage that, and we know we can manage it to get you your breaks and to get you your lunches. But the problem is, and you could see it like, just like I'm telling it to you, it started at 20 grand, And then people realize, well, shoot, every time we don't have a break, what if I get an extra 2 hours? Then it becomes part of their income, and then it becomes harder to take back. So we've been doing that. I think that law took effect of January, Randy? January? And we've gone from 20 to 40 to 60 to 100. And I don't see it going back, but that's why we need some of these leverages in the union contract. So when you look at our performance, we're not happy, but we think, I'm comfortable that we can get there. We have a big pickup from the health plan starting the first of the year that represents I'm not gonna take your thunder, never mind, go ahead. We'll get it back to A.
I do have one question along that. So you said you have 100 offers that are out. Do you have any idea how many of those will be accepted? And then how many travelers roughly do you have that would displace?
So we have total, I think, about 135 travelers, but not all of those are nurses. A lot of them are imaging, and even in some of the most routine places like dietary and security and places like that. The first 50 that we offered, we got about 43 acceptances. I think 1 or 2 dropped off. Now, understand though that then there's that training period for them, so it's kind of the double cost. We just did another, sent me a text yesterday, another 60 offers, and we expect to get that as well. So the challenge is keeping them. So we talk about a little bit the need for the union contract to be, the new one in April, on different union contract, to be really strong on that bottom piece. Because once we get to year 5 or 6, we're looking pretty good. And also they're vested, they start to understand the retirement, we can get long-term employees. So nursing has done a good job of making offers, and again, we push them to say we need to fill all these positions. We had budgeted a very aggressive travel reduction. We haven't hit it. Still the right thing to do. We're still pushing hard to get there as quickly as we can.
But that's potentially really good news, is what it sounds like to me.
Great.
There's really 8, 9 departments that are driving those traveler FTEs. Year over year, we have realized a 10 to 15% decline in those FTEs, but we did bake in a considerable savings target in this year's budget.
Okay, thank you.
And just to give you a little challenge, in emergency, for example, we have 37 of them. And for any of you who have been in our emergency room, it's not that far from a battlefield, right? It's really a complex, high-end, very acute emergency room. And unfortunately, the travelers are the new nurses that we just brought on board are being trained by the last group of new nurses that we just brought on board. So that experience gap is a little bit challenging sometimes. So we hope to keep them longer.
Should I keep going? Yeah. Okay, everyone has a slide. Okay. So looking, we can go. So were you waiting for me, Brandy, to go to the next? Yeah.
Who did the current?
Sorry.
Was that you?
So used to having the clicker. Yeah, we can skip this one. Go to
Somebody got too much time on our
yeah. No, I didn't. Yeah, I don't even know how to do that. I can't take credit for that one. Okay, so looking at our granular income statement, when we look at our gross patient revenues, we're about 2.5% above budget. So while our inpatient revenues are below, we've made up for it on the outpatient side. With that said, when you look at the overall yield rate between service, there's a considerable difference between inpatient and outpatient. Because of the way our managed care contracts are structured for trauma services, we get a favorable collections rate, whereas outpatient business is primarily government, which is a much lower rate. So I bring that up because when you compare the gross revenue to the net patient revenue, the yield rate is lower because of that shift in service mix.
Yeah, I just want to make a comment about that. In most institutions, outpatient revenue far exceeds inpatient revenue. From our perspective, though, we are almost 100% of a Medi-Cal hospital or Medi-Cal managed care hospital, with the exception of trauma. So trauma, we bill, our Kaiser rates for trauma are 94% of charges, which is really, really high. But again, maintaining a trauma center is significant. So in most worlds, we try very hard to build the outpatient business because that's what the margin is. Because our outpatient business is almost 100% Medi-Cal managed care, those yields are 15% on the inpatient side, 9% on the outpatient side?
Lower, actually.
Yeah, lower, so just something different than you might see in the public or the private or nonprofit sector.
Moving down to the expense budget variance by category, we're trending favorable when we look at the salaries and benefits line due to the number of vacant roles we just discussed. When we look at professional fees, the two key drivers there are travelers and then our physician cost. Because of the way the incentives are structured for our providers, those costs tend to be higher in the first part of the year, and then they tend to come down in the second half once our physicians have hit those targets. But obviously, we're actively looking to fill our vacant positions and find ways to rationalize those contractors. Supplies are above budget by about $600,000, and that's due to higher than expected surgery cases. Our surgeries are about 10% higher than our fixed budget. And then going down to purchase services, we're seeing a considerable positive variance there. Some of that is due to the timing of implementing some new projects that were planned this year. The 3M computer-assisted coding project comes to mind, which is going to help us even more in terms of coding our inpatient claims. And then utilities, in talking with the accounting team, we did miss an accrual at year end last year, which rolled into this year, so that was about $300,000. And in evaluating this year's budget even closer, we did not bake in enough expense based on our historical run rate in utilities, so we do have some exposure there going forward. With that said, we are reviewing our budget expense variances at the sub-account level to ensure that, you know, we don't miss that again going forward. Next slide, please.
And then Oscar goes to?
Can I ask, Abe, just one question. On your bottom line here, you're in the red 4.2 on a budgeted amount of 2.
Yes.
And so, I mean, if you were just to do round numbers, that's about $1 million a year in losses. I don't know what your year-end budget looks for, but is this kind of a rate you would be expecting from now through the end of the year?
No, we do expect that our revenue line is going to pick up even further in the second half of the year. We negotiated, or we came to an agreement with the health plan for a 7% rate lift starting in January 1st. So that's going to bring in about $2 million in additional revenue. On top of that, we've been working with CAPH on some modeling to increase our enhanced payment supplemental program funds. Right now, we feel very comfortable that we'll get at least a 15% lift. He's actually CAPH is actually aiming for a 50% rate increase. For us, that translates to about $10 million in annual incremental revenue. But we won't know for certain what the final rate lift is until the next couple of weeks.
Okay.
And then we'll be able to adjust our revenue recognition upward in the second half of the year once those rates are formally blessed.
Okay, thank you.
And then as Rick alluded to, as we fill these vacant traveler roles, or reduce our travelers, I should say, then we should impact that professional fees line as well. And here's our balance sheet. When you look at our cash balance, we are about $14 million lower than we ended last year. But that's mainly due to the funding of when we received those supplemental payments. We got a large chunk in October, which is reflected on this balance sheet. We got another large payment in November for about $11 million. And when we look at our accounts receivable, we have seen an increase in our AR. You know, we had a meeting yesterday with our PFS, our billing and collections director, along with her associate from Common Spirit yesterday. So they're actively working on ensuring that you know, we're collecting every dollar that we're entitled to based on our payer agreements. So working hard on that as well. Next slide, please. I'll let Rick take this one. No, I was kidding. No, this is kind of more of an eye chart. Just high level, we talked about our inpatient discharges. We're about 5% low.
I'm sorry, can I just back up for a second? How long do you carry AR? I mean, year to year before it's forgivable?
Yeah, after we reserve at 100% once an AR balance hits 360 days. So we don't expect to collect anything further. Yeah. You can go to the next slide, please. That's okay. So just a high level on our finance dashboard, I mentioned our discharges are about 5% lower than target. We talked about some positives on the volume side with our clinic visits. Trauma cases are about 4% higher. Deliveries trending very, very strong year over year and relative to plan. And our CMI, the acuity level of how we're coding our claims now has really picked up now that we've launched our CDI program.
And I think you want to call out the trauma cases, very, very important to us to see
Yes.
those over budget. Surgeries as well, those are really, really high numbers for the hospital. And the reason I bring it up is we're running into capacity problems in the OR. I don't know where we're going to build additional ORs, but we're running 7 ORs almost 24/7. Our ORs oftentimes go over to 7, 8, 9 at night, and oftentimes, well, I told you about that one day where in a 12-hour shift we had 22 traumas, 6 gunshots, 4 stabbings. I don't know where they all came from, but think about that. I mean, the OR that Saturday, the 7 ORs ran from morning to night. We don't staff them like that, so we had to ask people to come in. It was amazing that they all did. The work they did on that day was just heroic. I mean, it really was 22 traumas in 12 hours. My last place, we thought we were a busy trauma center. We saw 79 a month. So comparatively speaking, this trauma service is really important, and it extends far to the east, a little bit to the west, and they're really good. That's the best news of all that. They're really, really good if you look at their data compared to statewide. So that's something we should all be very proud of.
So I have a quick question. So surgeries are up. Why doesn't that cover the cost of supplies?
Our surgeries exceed our budget. Our budget is based on lower cases. So if we had a flex budget, you would have more cost in your budget to account for those higher volumes. When you look at our supplies, we're 3% above our fixed budget, but our volumes support that.
So the budget was set at 528, and let's just say prosthetics, right? Prosthetics are, let's just say $5,000 a piece. Instead, we're running at 628 instead of 538. So if you assume that most of those surgery cases have those prosthetics and it's a fixed budget, it's automatically going to be over because there were more cases done.
Okay, so that's just budget.
Yeah, so there's a revenue offset to that supplies, unfavorable supplies variance because of the higher surgeries.
Okay. Thanks.
And then while, just one note on our inpatient census, while it was soft through the first 4 periods, in the month of November, as Rick alluded to, because of those higher trauma cases, we actually hit our inpatient volume budget, which is not reflected here through October. So the following month, we'll share that.
And we would expect to see that in December, in January, February. March is questionable, but that's the real high respiratory sick months. So typically we see an uptick in census in those months.
And here's some volume graphs. On the top, you have patient days, top left, and inpatient discharges, top right. And you see the correlation. When you look at the blue line, which is current year, budget is red, and prior year is green. You can see that through the first 4 periods, the blue line, which is this year, has been down relative to both target and prior year level. And then down at the bottom, when you look at our average length of stay, we're essentially discharging patients at the time that we expected in our operating budget, but we're continuing to find ways to improve on that metric and open up beds for new patients as soon as possible. And then when you look at the bottom right, our deliveries, the blue line has consistently been above prior years, so definitely trending in the right direction there. Next slide, please. Here's some additional volume graphs. When you look at the top graph, the surgeries, you can see the blue line, current year. We've consistently exceeded prior year level and target. That's what's driving the supplies expense variance. And then at the bottom, when you look at our trauma cases and ED visits, trauma should actually be green, the little arrows. I know it's kind of flat, but we have grown or exceeded budget by about 4% when you look at the blue line relative to the red, which is the target. And then ED visits, bottom right, you can see that we've been down for the first 4 months. I know that our ED is always congested, so I actually verified this with our ED manager, and she confirmed that we have seen lower visits there.
So the real reason for lower visits is no COVID. I mean, when you think about the 2 prior years and the number of patients we had to house from a COVID perspective, that's the real reason the ED visits are down.
Go, next slide, please. Here's a couple of collections and AR metrics. When you look at year over year, our cash collections, both professional and hospital technical, were about 5% higher than we were same time last year, which it supports the revenue on our income statement, and it also shows that we're realizing the gains from all those revenue cycle initiatives when you factor in the decline in our inpatient business. So less inpatients, yet our collections are up year over year.
And December looks even a little better.
Correct. We're trending very strong thus far in December. Thanks, Rick. And then when you look at our AR days, we still have a lot of work in terms of bringing down those days. I know that the revenue cycle team is actively working on finding ways to automate our write-offs to bring down those gross AR days, and we're addressing that through the Cerner Revenue Cycle Uplift project. And then, yeah. And then here's the trend on our days cash on hand. Month over month, we did see an increase in days of about 10, driven by a considerable supplemental payment that we booked in the month of October. There was another supplemental payment received in November, so we expect that trend to continue upward. Still not where we ended the year, but we expect to get closer here in the month of November. Next slide, please. And here's the case mix index or acuity level of our patients. We kind of talked about this earlier, where because of the new CDI program and more collaboration between the revenue cycle teams and our providers, we're documenting our inpatient cases more accurately, which is driving the revenue line up and minimizing denials from our payers. Next slide, please. So here's a metric that kind of evaluates the overall cost structure for the hospital. So it looks at our cost per volume indicator normalized for acuity level. When you look at year over year, last year we ended at 15,500, our cost per CMI adjusted discharge. This year, even with the higher inflation impacting our cost line, year to date we're actually at 14,800. So we're better than prior year level. And when you compare to target, we're lower than target when you factor in the more complex cases that we're seeing this year, which is reflected in our case mix index. And then here's the contract labor that we kind of talked about a little while ago. So when you look at the blue line, which is current year, we're lower than prior year. But we still have a ways to go to get to the target that we established in this year's operating budget. The savings that we baked in this year's budget exceeds the year-over-year reduction that we've seen in those costs. And as Rick mentioned, when you look at the yeah, that's okay. On the right, you can see the departments that are really driving those contract labor FTEs, and it's, 8, 9 areas where we really have to focus on and bringing those travelers down.
Question, what's the goal? What's your goal?
57, yeah, that's our goal. We want to get down to 57 contractors. That's what we booked in this year's budget.
From 143?
Yeah, actually, in November, we did come down to 130, so it might be optimistic, but we're actively working on getting that line number down.
I just to address that, they had a couple things that we were very optimistic about oh, dang it.
Go ahead.
I usually don't need a mic, but a couple things that we were very optimistic about when we set the budget. We had a kind of a connection with a number of foreign nurses that we thought was going to happen, that was going to bring significant, I think 50 nurses to us at one time, all experienced, and that did not happen because I don't remember if it's an issue from the Philippines or not. We're still pursuing those kind of things, but we really thought we were going to get those. I believe it was 50 nurses, and that did not happen.
Okay, so here's our last slide. We referenced a few opportunities. When we look at the revenue model for the hospital, about 75% of our revenues are driven by the fee-for-service model. So you come in for a service, you pay for that service. The other 25% are based on the supplemental payments. So volume growth will be critical for us on the fee-for-service side, of course. In terms of additional opportunities, we talked about the quality metrics. Potentially, when you look at the overall pot, we could potentially leave $20 million on the table if we don't start improving on these metrics, as soon as possible. But I know Greg and his team are actively working on that. On top of that, we talked about the enhanced payment rate lift. CAPH feels very strongly that at the minimum, they'll be able to secure a 15% increase, but they're aiming for 50%, which is great. And then the rate increase from the health plan that we agreed to with Lizette, that's going to bring in a couple million as well. And then the Cerner revenue cycle uplift project, the team, we're encouraging the team to figure out ways to automate some of these routine tasks within our billing and collection space so that we can focus on those high ROI accounts and collect every dollar that we're entitled to based on our payer agreements. On the cost side, we kind of touched on these, the traveler nurses, huge initiative at the hospital to bring those costs down. There's a new tool that we're exploring with our director of materials management called SurgiTrack tool. There's a demo tomorrow that Rick and I were asked to attend. This tool is gonna optimize PAR and space optimization, and then improve our efficiencies and potentially increase our revenue by charging for some additional supplies.
It also should build capacity in the OR. If we're more efficient in our OR, obviously we can do more cases in a day. So because we can't easily build another OR room, we're doing everything we can to maximize the number of cases that we're doing now.
And then in our lab space, we're looking for opportunities to increase productivity there so that we're not sending out tests to Quest Lab, for example, and we're retaining those volumes internally at the hospital.
So I want to bring this up just because I think it's important as we try to collaborate. It's really confusing. The health plan has 300,000 patients, right? And they have some of them associated. We own 50,000 lives specifically, and we're capitated for those lives. So that means those lives are supposed to come to our laboratory. We don't really bill for them. We collect it per member per month. Because there's other, because on the clinic side, their reference lab is Quest. Now, understand that this population is hard to differentiate. So when a clinic person utilizes our lab, we send the bill to the health plan and we're denied because it went to the wrong lab. But there's no real easy way to differentiate. So we just picked this up about a week ago. Once we had a meeting with the health plan, we realized we had all these denials, and we're thinking, how can our partner be denying us 70% of the time? And we realized a whole bunch of it was these miscellaneous labs. And then as we dug a little deeper, we found a lot of things. We're spending $3.2 million on lab send-outs. That number should probably be less than $1 million. A big part of it is, and I'll give you the perfect example. So a health plan, life assigned to the clinics came to the hospital. We sent them to our lab because it's hard to differentiate. The test that was ordered was a panel, a very expensive panel, right? So we sent the panel to Quest. Now, realistically, the patient should have gone to Quest in the first place, and there would have been no cost to the hospital. But because they came through the hospital lab, Quest billed us $1,400 for that test, right? So there are two issues there. Number one, no reference lab bill should exceed Medicare reimbursement. So we're negotiating now with Quest to say this is BS. You know, you either get your rates down or we're going to, you know, RFP it and get better rates. But the other things we found out, and just, you know, every time it seems like we turn over a rock, we find things that are, you know, we had a doc that decided he didn't want to use our pathologist. So he was sending his GI slides directly to Stanford. So bills from Stanford were coming back at $2,200, non-reimbursable. And we collected on the GI procedure probably $400. So we identify these things too often, and we're taking action as quickly as we can. And you look at our shortfall of about $2 million, we really think we could make it up if we just can, you know, just be more efficient, understand the contracts better, work with the health plan to say, look, maybe if it's a life that's assigned to the hospital, make sure you identify it, blue form, yellow form, however you want to do it, because all of those patients that are not, we're kind of getting, you know, paying for the cost and not getting the reimbursement. So just little things like that we can do better, and that's why we have to be, that's why we have to meet as a healthcare organization on a regular basis so we can quickly address these issues that are just flow issues and certainly improve our bottom line. So
Can you explain the whole Quest thing? So it's cheaper for them to contract with Quest? You lost me there.
well, for whatever reason, it's not very common that a hospital lab would take a capitation. And in most hospitals, I wouldn't even recommend it. In ours, I would say differently because it's such a sophisticated, automated, amazing lab. It really could handle the Quest contract. We had decided as a hospital with a health plan that we would take responsibility for our patients. Those are the 46,000 we get the per member per month for. But the clinics decided, along with the health plan, that they wanted to use Quest for their lab. You know, they pay Quest a per member per month. I don't know if that's the right decision or the wrong decision because I haven't been able to look at the data. But where we're losing money is by not assigning those people correctly. So again, when a health plan patient or a clinic patient comes to us and we mistakenly do the lab, it costs us money. And then if we send it out, it even costs us more money, right? And if they go to the right place, those costs just go away. Now, maybe in the future, we can do this differently where the hospital lab can control the contract as long as we have a secure contract with one of the other reference labs to make up for our very expensive tests, right? Because you don't want to, capitation will kill you if you can't control your costs and you have and you can't control your usage. But we control, now it's confusing because, you know, 75% of the patients are supposed to go to Quest, 25% of the patients are supposed to go to the hospital lab, and there's no real easy way to differentiate because they, you know, person might come to a clinic, he might need an ENT, he sends the to us, the clinic sends it to us, it's a clinic patient, we do labs, we automatically do them because they're there in our specialty clinic. That's an opportunity. It's not a bad thing. It just took us a little while to figure it out. And we found a lot of those things in the, you know, in the year that we've been working with the MSA. And we try to take opportunity as quickly as we can. This is a big opportunity that we didn't see. And it's a potential couple $1 million to the bottom line. So.
And one note outside of the current year financials, we've been meeting with our external auditors on a weekly basis, CLA. And within the next couple of weeks, they're looking to wrap up last year's audit engagement, so it won't take a year, Jay, to kind of finalize it like we did last year, so. No friendly reminders from Jeff.
You get an A in mind reading, by the way.
And the overall preliminary audited financials, no major surprises from what we shared.
Okay. Thanks. Are there any questions for our hospital folks? Okay, no questions. We will move on to public comment. Any public comment? Anybody out there? No? Okay, thank you. The last thing would be committee comments. Are there any comments from committee members you'd like to make?
Jay, I do. We have our HRSA operational site visit. It's been scheduled for January 23rd, 24th, 25th. The due date for our document upload is January 9th. We've been going through a series of mock on-site visits of the 93 elements that are required for a HRSA designee. We have 34 of them that are at risk. So we've been going through a series of now technical assistance. A lot of these are easy to fix, such as contracts don't embed our sliding fee discount, that doesn't document, it doesn't state where the visits are documented and how credentialing are done. So we're going to be repapering some of our providers with amendments to get those items in there. One of our huge gaps is a required service with dental. We're not doing dental right now, and I had a very positive engagement with Christine Noguera from CMC and their dental medical director. We're working to basically get a contract in place that will provide us HRSA compliance, have that in place by the 9th, but also a very good collaboration with Christine because it's going to be a bi-directional relationship, getting started with the compliance with dental with probably cleanings and a referral pattern, but a lot more dental services will be started to be provided within the clinics, and that is probably the largest exposure we have for continued HRSA compliance. Working on bringing on an interim chief operating officer. That position's been vacant for about 4 months. I think we're close to resolving the conflict between councils, and with that, working to stand up the liaison committee.
I just have a comment. I always wondered, like, the county's responsibility with the clinics because they have their own board. And a lot of this bottom line comes out of the county's budget. So it just kind of blows me away, the oversight of, you know what I mean? And that's what I'm finding in the county. A lot of committees and organizations have the outside oversight. And how do we control that? You know, because, I mean, we go through this, and I mean, had this not come to kind of a head, where would it have gone, you know what I mean, financially, if you have somebody, a director, spoon feeding at board, something that they think is right or whatever their agenda is, what are the checks and balances at the county level to make sure that this doesn't happen?
So my role is rebuilding those partnerships, and I think it really needs to be a lot closer partnership versus the clinics going independent. But in order for us to have the FQHC, which has a lot of positives on the revenue side, getting a quasi cost-based reimbursement, we need to have this nonprofit board because our governing board does not represent the demographics or clinic users. So it's a requirement and a lookalike status that we have this nonprofit board. But I think the revised co-applicant agreement gave a lot of authority to the prior CEO and this nonprofit board. HRSA, that nonprofit board, has plenary authority over the scope of services and the mission, but the county as a public entity applicant should retain fiscal controls, human resource controls, procurement controls, and I think that's really where we need to bring some things back, but ultimately build shared understanding and looking at the future on ultimately how we both focus on the mission.
Okay, because that.
I'll add a different piece. I have a different perspective on that. So this board was handpicked by leaders who, in my mind, didn't have the best interests of the patients in mind. I'll just start with that. And they took unprecedented amount of QUIP dollars from the hospital, and I keep telling you that QUIP dollars belong in the hospital, not in the FQ. So they come out with this new board, and for a year and a half, they're told how great we're doing. They're told how great we're doing. They're showing financials that look positive, even though their performance, and again, no disrespect to the people that did the work, this is a leadership issue, even though their performance was the worst in the state. That never came up to the board. From their perspective, everything was wonderful. And why is this guy from the hospital so pissed off at us? What is it? What is it? Well, so their perception all along has been misinformation. So at least we can do is sit down with the board and say, here's what your real revenues are, and here's what your real costs are, and understand why we need to look at this differently, right? I mean, it's a perception issue from the board where they were told all along that, you know, we're trying to interfere where we don't belong. This was an agreement they made. It's a really bad agreement. And, you know, my biggest issue, guys, that is simply this, and I look at revenue as something that we really, really need. We have 50 contracts still that were added to the FQ. We have 50 contracts that were added to the FQ. Their cost went from when they were running with the hospital at 21 million in 3 years to what we're projecting now at 48. In 3 years, we've gone from an expense of 21 to 48. The board should see that. If they're a conscientious board, they should say, explain to me these increases, because maybe they're valid, right? But none of that was done. It was just, this is a perfect picture. Look how great we're doing. Look how great we're doing. We gave doctors, you know, schedules that we can't live with. I'm glad we identified it, and I'm glad we're working on it quickly, but at some point, for the board to be effective, they should understand the true picture of where they are. That would be my recommendation.
And Supervisor Canepa, I just want to add a couple of things to that is your board, the Board of Supervisors, has ultimate authority over the clinic's budget. And as you may recall from June, that item got pulled and not voted on, not approved for a board meeting, kind of as a bell ringer to let the clinic's folks know that there were some serious issues going on, as you just heard Rick describe, and we weren't going to let those just fester for another year. And that if this happened in June, we'd be having a much different discussion about that. The other thing that's critical, and you heard Greg talk about the liaison committee, where you've got the partnership, the two board members from each side, along with the CEO from the clinics, to be able to referee this so we don't get that far. And kind of as Rick was just mentioning, there was about a year and a half, and I will say we had a lot of emphasis on the MSA with the hospital, because that was actually our biggest issue at the time. And for whatever reason, I won't get into speculating, the clinics went way left to Albuquerque in that time.
Okay, and then so on the clinic side, that whole negotiated rate for Medi-Cal, is that being worked on so that eventually, you know what I mean? Because I think that's what Dr. Perdue originally said, that, hey, you know, once we get this up, then we won't be as reliant on the QUIP money. Does that have validity? So, I mean, it's just hard because you have lay people, and I mean, I'm trying to learn as quickly as possible, but it's very daunting. So when you have somebody that's not helping the board and teaching the board, and you know what I mean, and what their role is, and, you know, you have folks that have great intention, but I mean, I don't think that they got the information that they needed.
And I would agree, there is some excess there. I need to get through the operational site visit cleanly so we can secure the renewal of the HRSA designation. But via the budget process, and even before the budget process, I'm tasked with bringing a update to the full Board of Supervisors at mid-year on the status of the Este Health's budget. I'll be working with Brandy in the CEO's office to also make some recommendations to start right-sizing, start some cleaning up. So these things are on the board, but right now my focus is making sure that we successfully retain the HRSA designation with the on-site visit. But to your point, I mentioned during the financial update how the new PPS rates and the aggressive strategy of let's ramp up a cost in the numerator for a new PPS rate, and therefore it will pay off over time with increased rates. Given 5 years waiting for the hospital CMS cost report to close out, and as I mentioned, some of the items that we proactively went to DHS audit investigations probably would not be compliant. I think a request for a change in scope or new rates are off the table. I mentioned the strategy now is pivoting towards those intermittent clinics, and if we can actually do that, a pickup of $6.7 million in top line revenue. But I think it's a combination of increasing the revenue, decreasing the excess, and repartnering such that collectively we can draw down 100% of the QIP monies for the counties.
Okay, thank you.
Are there any other comments from any of the committee members? Okay, I just wanted-
Just last comment. I do still think, I would like to see, I'd like you all to see the increased costs and where they came from. That'd be a good thing for us. So what happened from 21 to 22 to 23 might be a good opportunity for you to, have an understanding.
And I'd say a lot of that was in the first couple of years of QIP. It was pay to play. We've onboarded people in business intelligence, but I would admit there is some excess there. Everywhere I go, they got brand new furniture, brand new flooring. So some of those are one-time costs I can't claw back. But indeed, I think more transparency would be beneficial.
Thank you. And as elected, that's the hardest part of our job. You know what I mean? Is to sit there. I mean, I'm a business person also, like the Manteca Clinic. Why did it reopen? I mean, if you're losing money, who fed them the Kool-Aid that was something that was effective? I mean, from a cost perspective, I mean, it's not. Are you generating enough revenue to cover the cost? And do you have the people to cover the cost? It just.
And I don't know if the prior leadership was, hey, let's grow. We're pre-IPO, growth at all costs. That cost was being provided by, as I mentioned, 24% of our revenue is QIP. The health centers only get QIP by being affiliated with the public hospital, but we do this together, and I want to rebuild those partnerships. I think prior leadership was, their goal was to be autonomous.
I believe the motivation was to chase the competition. So CMC opened in Manteca, we wanted to open Manteca. CMC opened in Lodi, we want to open in Lodi where we probably have the least percentage of underserved patients in the whole county. So I don't think the strategy was, how do we, again, the job of the FQs, and Christina could be a good partner with us. The job of the FQs is to make sure there's access to where the patients are. So if, for example, CMC, and I say CMC is a good partner because they give us a lot of work. So if CMC's in Manteca right now, why do we need to be there, right? We're getting revenue from their patients. They have a favorable position of the place. Again, a 10-year lease at $20,000 a month where no patients are coming. And locums, the reason I brought it up is I would say the same thing you are. Why are we there right now? Why don't we backtrack on some of those expansions until we get it together? And I think there's an opportunity for CMC to take that lease.
That's what I'm learning. And I mean, obviously, in the Lodi case, if you need 9,000 folks and you're going to split it between 2 clinics, if your break-even point's 9,000, I mean, I'm a dumb car wash guy and I can figure that out. You know what I mean? So I hope that people see that, and I hope that information is brought to those folks, because if it doesn't pencil, it's not going to get any better. I mean, and the cost is only going to escalate, as we've seen, and you're fighting for the same employees, which sometimes they pay more, and then we're battling that, and because how do we sell benefits versus money in their pocket? I don't know.
So here's a thought process that I think could be an opportunity to bolster care, improve access, and just do a better job overall. CMC has done a good job. CMC 2 years ago was losing a little bit of money. They don't get any QIP money. They don't get any of the money that our FQs are getting. Christina's to the point where she's ready to retire. They just increased their PPS rates. That's how they went from being a little short to back to very profitable. we should entertain looking at an affiliation with them, because there's a number of opportunities. Number one, we're not duplicating services, we're not competing against each other. Number two, they see a lot more volume, so our potential public funds monies would be significantly higher. They just renegotiated a new PPS rate, which means their rate of reimbursement is higher than their cost. It might be a great opportunity to say, how can we partner together and, you know, have access for the community using their expertise, because the opportunity, so for them, having these, you know, pretty good results, nobody benefits. There's no QIP money going to any hospital. If we had some kind of relationship that allowed that QIP money to flow, it could be a significant opportunity.
So collaborating instead of competing.
Yeah.
Okay.
There would have to be some kind of ownership from a county perspective for us to receive that QIP, but anyway.
Yeah, they would have to basically be the county affiliate, but this is kind of a Foley and Lardner question of how that would happen, because all the other public hospitals, their FQs are a lot more embedded in their public hospital space, and unfortunately ours went adrift.
Thank you.
Okay, any other comments? I just have one, and I continue to be encouraged as we have our monthly meetings about how collaborative we all are between our organizations. The fact that we're getting our hands around some of the key issues that have been lingering and then biting us and moving forward in a really, really good direction. So I appreciate everyone's participation in that.
Jay, just, would it be beneficial for us to have Lizette at these meetings?
Probably so.
Yeah.
Yeah, we can certainly include her. It's a public
Because I
meeting.
know all Lizette wants is another meeting, so don't tell her that Greg brought this up, would you please?
Yeah, I go to 2 health plan meetings a month, why not, right?
But it goes to the whole point that this is a partnership, and even though they're a local initiative rather than a COES or an alliance model, we are the safety net, and we sink or swim collectively together, and there's a lot of opportunity that we've not been able to take advantage of.
Okay, I think that's a great suggestion. With that, I'm going to adjourn the meeting at 10:08.